start.
Uh, Good evening, everyone. I'll be presenting an audit on diaphragmatic hernia today. Uh, a 72-year-old female patient presented with complaints of pain in abdomen and abdominal distension since 2 days. Pain was generalized within 2 days and was unable to take orally. Patient had passed flatus stool on the day of presentation. Patient did not have any comorbid conditions. She did not have any history of trauma and she did not have any past operative history. On general examination, temperature of the patient was normal, pulse was 90 beats per minute, and blood pressure was 140 by 90 millimeters of mercury. Patient's general condition was good and patient was mobile. On respiratory examination, bilateral air entry was present and was clear. On per abdomen examination, abdomen above the level of umbilicus was distended. Rest of the abdomen was visibly normal. On palpation, abdomen was soft and non-tender. There was no evidence of organomegaly or any palpable lump. On auscultation, hyperperistalsis was present in the epigastric region, but peristalsis in the rest of the abdomen were relatively normal. On per rectal examination of the patient was normal. Patient was kept on abdominal girth charting, which was static for the 2 to 3 days that she was kept conservative. On blood investigations of the patient, hemoglobin was 13.5 grams per deciliter. Total counts were 9200 per cubic millimeter. Creatinine was 0.69 grams per deciliter, and sodium and potassium were in normal range. On chest X-ray, right diaphragm appeared to be elevated, and right lower zone showed basal plate atelectasis. This is the X-ray of the patient.
The X-ray shows a very elevated right dome. Show the X-ray again. Yeah, see,
yes,
if you can see the left side and the right side, in the left side, what you see, the fundal gas shadow. It is below the cardiac
yes,
shadow, quite lower down as compared to the right side, where you can see some air fluid level or some air in maybe between the diaphragm and between in the lower part of lung or whatever. So there was some doubtful for sure. There was some doubtful shadow. We were not very sure. The only thing probably if we can have a screening, if you can get screening and if you can see any movement of the diaphragm, probably it would be good, right?
If you get lateral X-ray, that is also important. If there is an air fluid level, so is it an anterior part which is showing air fluid level, or it is posterior part?
Yes, yes.
And that will also be indicated by this X-ray. Okay, next will be lateral X-ray and screening.
Yes, sir.
Based on this X-ray, we cannot exactly differentiate whether it was diaphragmatic or whether it was herniation of the contents or event duration. It could be both because this also appears like an elevated right side of diaphragm. We went for USG of the ultrasonography of the abdomen, pelvis, and thorax. Few of the visualized small bowel loops appeared dilated and content filled and showed to and fro movements with average diameter of approximately 27 to 28 mm. Minimal fluid was noted in peritoneal cavity. Mild free fluid was noted in right pleural cavity with underlying lung showing air sonogram. On USG, we could not appreciate any signs of diaphragmatic hernia.
Wait. And this USG was done after insertion of rise tube or without insertion of the rise tube?
This was done after insertion of rise tube, but the patient had an outside USG, which was also not suggestive of presence of bowel loops or any signs of bowel loops in the thorax. Actually, patient came to us with an outside CECT. That is why on presentation, we first went for rise tube insertion and then we got the workup done.
Okay, so you have some doubt before doing USG. Oh, good.
Yes, yes.
So that is the advantage of tertiary center. You have not
Patient
to.
came to us with a CT abdomen itself.
Okay, okay.
On CCT abdomen and pelvis, a large wall defect was noted within the anteromedial aspect of the right dome of diaphragm with herniating large bowel, part of the distal transverse colon, hepatic flexure, and part of the ascending colon, and few of the distal ileal loops, along with the small bowel mesentery and part of anterior omentum. The defect measures approximately 4 by 2 centimeter. The rest of the large bowel loops appear collapsed. Cecum and proximal ascending colon lie within the peritoneal cavity in the right lumbar region. Terminal ileum was collapsed and was seen within the peritoneal cavity in the right upper quadrant. Transition point was seen in the distal ileum at the site of diaphragmatic herniation. There is resultant dilatation of proximal and mid-ileal loops and distal jejunal loops with maximum diameter of 3.6 centimeters. No definite wall thickening was seen involving the herniating bowel loops, and stomach was over-distended. There appeared to be twisting of the mesentery due to the diaphragmatic herniation. Mild to moderate fat standing was seen involving the small bowel mesentery and part of the anterior omentum herniating through the defect. Multiple subcentimetric size lymph
So
nodes were
what?
seen. Yes, sir.
Hello.
Yes, ma'am.
I was just confirming. Is it audible or not?
Ma'am, I don't know. Okay, ma'am, should I continue?
No, but go back. That what you said last. No, not backslide. Last two
Okay.
sentence because it was not audible.
There was twisting of the mesentery. There appeared to be twisting of the mesentery due to the diaphragmatic herniation. Mild to moderate fat standing was seen, involving the small
So there
bowel
was a
mesentery.
twisting of mesentery. They have written twisting.
Yes, ma'am. In CECT they had written, ma'am.
Mesentery of small bowel.
Yes, ma'am.
Okay, that is usually uncommon. Whenever there is a diaphragmatic hernia in the anterior part of the abdomen, so mostly Morgagni's hernia, there will be a transverse colon which goes up first most of the time. So does they mention about transverse colon anywhere or only the mesentery?
Yes, ma'am. Ma'am, they had mentioned that first they had mentioned with a herniating large bowel, part of
Okay.
the distal transverse colon, hepatic flexure, and ascending colon,
Okay.
and few of the distal ileal loops. So, and the proximal and mid ileal loops were dilated due to
Okay.
herniation of the distal ileal loops and colon.
Okay.
Multiple subcentimetric size lymph nodes were seen. Minimal free fluid was seen within the peritoneal cavity, predominantly in the perihepatic, subhepatic regions, right paracolic gutter, and in the pelvis.
So whenever they say there is a fluid is seen, then it is what do you mean by fluid is seen? Normally in any hernia, fluid is not seen. So what does it suggest if the fluid is seen?
One of the causes could be if the hernia is obstructed and has caused a breach in the bowel wall that can cause appearance of fluid, or it could also be because of excessive inflammation of the bowel loops.
Inflammation of bowel loop give rise to minimal collection of the fluid. And
Yes,
if this much bowel has already gone into the higher up into the chest, has developed diaphragmatic hernia, then subdiaphragmatic fluid collection will not occur. It will occur inside the chest wall. So if it is subdiaphragmatic collection, then you always think about two things. One is it is because of some gangrene is developing, or there is a ischemia which has given rise to extension into the peritoneal cavity, which has given rise to inflammation and the fluid collection. Right? Perforation has not occurred. Even if perforation occurs, it is fluid collection occurs into the sac of the hernia. Right? Okay.
Yes, ma'am. Yes, ma'am.
Urinary bladder was well distended. Diffuse asymmetric wall thickening of the urinary bladder was seen with maximum thickness of 8 to 9 mm, and no obvious mass lesion or vesical calculus was present. Findings were suggestive of obstructed right diaphragmatic hernia with no obvious signs of strangulation, and diffuse asymmetric wall thickening of urinary bladder with query changes of cystitis, query obstructive uropathy.
So is it a right-sided diaphragmatic hernia, anterior or posterior? Does they mention?
Ma'am, they had mentioned in the CT that the defect was
Anterior.
in the anterior part,
So it is a
anteromedial aspect.
Morgagni hernia. Normally, what they say, as per the theory, that it is more common on the left side.
Yes.
As last
Yes,
time
ma'am.
you said that it is more
Yes, ma'am.
common on the left side, but right side is also not common. Okay. Right side is also common. So here it is a right-sided obstructed hernia. So how much percentage of patient develops right-sided obstructed hernia?
No, I don't know the percentage in of right-sided obstructed hernia, but among the congenital diaphragmatic hernia, relative percentage of Morgagni is 2%.
Yes. Okay.
These are the CCT images of the patient. As we can see bowel loops have herniated into the thorax.
From the anterior part of the diaphragm. Very well seen.
So show me where is diaphragm.
This is the diaphragm.
Where is diaphragm?
The dome that is seen posteriorly, it is going up to the it is attaching to the rib, and anteriorly we can just below the three bowel loops can be seen, and below that is the line of the diaphragm.
So why do you want to see the age of the diaphragm? Why do you want to see the age of the diaphragm?
Sorry, ma'am, I didn't get the question.
Why do you want to see the age of the diaphragm? In CT,
because to differentiate between eventration and
yes, you have to be very careful whenever you are presenting case. So age of the diaphragm is important. So how much width is there, then you can plan out accordingly. Okay. Because you have to ask for mesh. Right? Okay.
Yes.
Yes. Yes, yes.
These are sagittal sections of the patient on CCT. As we can see in this image, these are the herniating bowel loops into the right thoracic cavity, and they have also partially shifted the mediastinum towards the opposite side.
But you can see the stomach shadow. Stomach shadow is going upwards. Gas shadow. It is going upward. You can see bowel is also going upward with hair fluid level also. Okay. And here the liver shadow is not seen. Whenever you are seeing all the bowel shadow, but liver shadow is not seen in this plate, in the initial plate. So it is the anterior line, and then posterior line liver shadow is seen, in which continuity of bowel is not seen. Right? Okay.
There were two options for this patient. One was urgent exploration, and the second was elective exploration. We went for urgent exploration.
What was the RT aspiration? Why do you want to do urgent exploration?
Ma'am, RT aspiration was in stat 200 cc gastric output was present on Riles tube insertion.
Okay. And
Ma'am, but per
was
abdomen.
it hemorrhagic? Was it hemorrhagic? Blood
No,
thinning?
ma'am, not hemorrhagic.
Okay. Then what is the indication for doing the urgent exploration?
Ma'am, on per abdomen examination, there was significant distension of the upper abdomen.
So that is the
Even though,
one indication. There was a distension suggestive of obstruction. Second,
ma'am, second is that on on CCT findings also, there was a definitive transition point. And it was also suggestive of twisting of mesentery. So
so that
even
is
if
second. Twisting of mesentery is the second indication for a emergency. Third, as you said, fluid, subdiaphragmatic fluid. Third, fourth, what was oxygen saturation when patient came to you?
saturation was normal, ma'am, it was 98% on room air.
So all the patient who is going for surgery should have a pre-op oxygen saturation. Always see for pulse oxygen saturation with pulse oximeter. That is important. Okay, then patient had already underwent CT scan outside, and patient was on conservative management for 2-3 days already, right? So when they say twisting, it requires emergency exploration. Otherwise, you can wait. See, all the diaphragmatic hernia do not require emergency exploration, but once it is diagnosed, you will not wait and post it for emergency. Okay.
Intraoperative findings. An upper midline incision was kept. Approximately 50 cc of serous fluid was present, which was drained. Part of the transverse colon and few small bowel loops were seen to be herniating into the thoracic cavity. They were reduced back into the abdominal cavity. A 4 by 3 centimeter defect was present in the diaphragm on the right side anteromedially, approximately 1 centimeter, 0.5 centimeter from the sternum. Sac was identified herniating into this defect, which was reduced. Entire bowel was otherwise normal.
So how do you reduce? See, just explain how it was started. See, it was operated by abdominal route as patient was having obstruction. That is the main indication for going through the, see, there are two methods. One is by thoracic method and second is by abdominal route. So whenever there is a complication of the diaphragmatic hernia, that is the main indication to go through the abdominal route, because pulling the bowel loops or pulling the organ from below is better rather than pushing from above.
Yeah.
So
Yes.
whenever there is an obstruction, see, in hernia, we like to explore on the sac side. We always open up the fundus and operate. But here you will not open up the fundus and then operate. That will not help you to reduce the bowel loop very well, and you are not able to manage higher up into the thorax. So obstruction you must explore from the below, right? If required and you are not able to dissect out, then you can go for thoraco-abdominal extension, right? Okay. How will you reduce? Now tell me.
Ma'am, gradually the contents were pulled one by one, as in each loop was gradually.
So how
pulled,
will you pull? How will you pull? How will you pull? That is important.
Actually, ma'am, we were quite lucky.
Was you scrubbed? Hmm?
Yes, ma'am, I was scrubbed.
Kashi, you were scrubbed? Yeah, she was there. She was there.
Oh, okay. So how was it reduced? Tell me, how was
Actually,
it pushed or pulled? See,
It was
it's
pulled,
important.
ma'am.
in any diaphragmatic hernia, whenever you are reducing the bowel and pulling it down, then don't handle the mesentery of the bowel. See, I had seen 2 cases done by others while there was a bleeding, a torrential bleeding from the mesocolon. So whenever you are reducing the omentum or the bowel loops, you go from the outside, the outermost part of the content. Pass your fingers out from the outside part of the sac, and then you reduce all the bowel loops. Simultaneously, one hand, left hand is pushing, pulling little bit gently, and you are pushing all the contents from above. See, you are most of the time you are able to pass your hand between the sac and the content.
And yes, ma'am. So basically, what we did was that the transverse colon a little bit I could pull it from out from below only. Then I passed my whole hand and between the sac and the content, and then slowly pushed it down rather than pulling it out.
Yes. So pulling and pushing both is done most of the time, but you can pass the fingers in between. See, just pulling from the mesocolon give rise to, if there is a any mesocolic vessel is torn, then it gives rise to very torrential bleeding. And I had seen in 2 patients, so it's very bad and difficult to manage. Yeah. Okay. If it is a liver, what will you do, Kashmi? How will you deliver liver?
Liver should be delivered by pushing from above.
So most of the time, first you deliver the colon and all these things, colon and the stomach, and then liver comes. So it starts from the left side. So left lobe of the liver, rather than going from the right side, left side delivering is easy. It is almost avascular. Triangular fold is there. And so it is easy, but whatever is easy is to be managed by pulling it down. It's not hard and fast rule. Okay.
So always reduce the bowel burst so that you get enough space to mobilize the, if at all that is any adhesion, move all around the liver and then slowly push it down or pull it down, provided everything else is down.
See, I remember one patient. Yes, continue.
Yes, ma'am. No, ma'am. No, you are saying something.
I remember one of my patient while for the obstruction, patient was operated outside in Anand. And during surgery, patient developed cardiac arrest when they find out there is a obstructed diaphragmatic hernia. And so patient developed cardiac arrest. So they revived the patient and kept this tube stomy into the cecum and shifted patient to civil hospital. So we re-explored this patient. Patient was around 80 years. And so we re-explore, and in emergency, we just resect out the bowel and brought out this both the ends and did this do right hemicolectomy, and we did iliotransverse anastomosis, double barrel anastomosis. Bowel which was present inside the thorax was not possible to deliver because of chronic obstruction, and patient was deteriorating. So we kept it as it is and kept it ICD. And that ICD got blocked. So next day I decided to remove this ICD and then reinsert the ICD. So while removing the ICD, the whole loop which was present into the thorax that came out with the ICD. So this thing also can happen.
Okay.
So that was removed, just like how we roll this worm. I forgot the name of the roll on this matchstick.
Yeah, so, got it. Yes.
So tape we remove that tube like this bowel from there.
Yeah, got it.
Yeah.
Okay. Continue, Kashi.
Entire bowel was otherwise normal. The defect was closed with Vicryl 20 simple interrupted sutures. And a plain, and we also decided to do mesh mesh plastic. So a plane was created between the rectus sheath and the peritoneum, and similarly between the diaphragm and the
Have
peritoneum.
you removed that sac, excised that sac or not?
Yes, ma'am. No, ma'am, not. We just reduce the sac.
We
Reduce
pulled it
this.
out, ma'am. What we did was we pulled the sac out. Yeah. And then
And
Pankaj Bhai
plication
was
was
there.
done.
We
Plication done.
went above the. No, yeah, yes. Plication was done, but before that we went extra peritoneally between the falciform ligament and the sheath,
Okay.
reach the preperitoneal plane. If we close the defect and then we put it a proline mesh in such a way that part of it falls on the diaphragm and part of it will be on the entry abdominal wall, but extra
Okay.
peritoneally.
Okay.
So the idea was to go between the falciform and the entry abdominal wall and find out extend the mesh over the bare area of the liver,
Okay.
and so that a part of the mesh falls on the anterior wall and not inside the abdomen.
Have you got figure of this? No.
Ma'am,
Photograph.
instead of I have
Photograph.
one.
No, actually,
Ma'am, this one picture we have. Uh,
this is
ma'am,
the
this is the
actually,
mesh.
ma'am, we had photographs of.
Okay. Show it.
Where is
Kashi.
the diaphragm and where is the
This is the mesh has been fixed to the fixed above the defect. So diaphragm is at this level, and we have closed the peritoneum here, and then the
Yes.
mesh was placed on the peritoneum, and then rest of the layers of the abdomen were closed over the mesh. So the mesh was between the peritoneum and the abdominal layers anteriorly, and between the diaphragm and the underlying peritoneum on the superior aspect. It was
Okay.
extra peritoneal over the entire extent. So
Okay.
it also covered the primarily repaired defect, and it was reflected over the anterior abdominal wall.
Okay. Very good.
actually, ma'am, we have some good pictures, but unfortunately, because it was done in trauma, Kona passes some anesthetists have taken the pictures, so we don't have all the
Okay.
pictures.
Okay. Okay.
Right.
So, but it is very well seen in this picture. Okay.
Yes.
So plane was created between the rectus sheath and peritoneum, and similarly between the diaphragm and the peritoneum. The peritoneum was closed with Vicryl 20 simple interrupted sutures, and a 15 by 15 centimeter proline mesh cut to adequate size was fixed to the diaphragm with Vicryl 20 simple interrupted sutures covering the defect. The mesh was reflected onto the anterior abdominal wall and spread in the preperitoneal plane and was fixed to the overlying sheath with Vicryl 20. The sheath was closed with PDS 1 number continuous non-locking sutures. An intercostal drainage tube was inserted in the right fourth intercostal space intraoperatively.
See, if this is on the left side, then left side there is a pericardium. And so sometimes it is difficult to go preperitoneally on the left side if it is a very large hernia. So in that case, if you are not able to go preperitoneally or in the upper part of the diaphragm, then you can put the mesh inside also. Proline mesh can be sutured inside,
Yeah, or we can use a double layer mesh,
just like
or we
IPOM,
can use a double layer mesh.
a double layer mesh, or you can
Yes,
use
I
double
pump.
layer mesh. Okay.
Post-operative course of the patient. Um the ICD output was 250 cc
So do
serum.
your all the patient requires ICD or not? That is one first thing.
All the patients don't require ICD, but
Yes.
as
Yes, if it is a small hernia, do not require ICD. See, if you are closing this defect while doing placation, at the last stitch, you just ask the anesthetist to fully inflate the right
Inspire.
side of the lung, and then you take last stitch. And then you instill saline into this part, and see that any air is leaking or not. If air is not leaking, do not require ICD insertion. For a smaller hernia, it do not require ICD insertion.
Yes, ma'am. Yes, ma'am.
Continue.
Post-operative course of the patient. The ICD output was 250 cc serum hemorrhagic on post-op day 1, but decreased to 10 cc serous on post-op day 2 and 3 consecutively. The patient was maintaining 99% saturation on room air, and post-op chest X-ray was clear. So ICD was removed on post-op day 3. And otherwise the post-operative course was uneventful. On follow-up, patient came to us with a healthy scar and no complaints. This was the X-ray that was done following the surgery. With we can see the ICD in situ, and after this X-ray, we had removed the ICD.
So what will you see post-operatively? One is ICD output. What else?
Ma'am, chest X-ray. Whether air entry and saturation of the patient.
Immediate post-operatively, there may be a raised intra-abdominal pressure. As you said, there was a whole transverse colon, ascending colon, small bowel, liver, everything was there. And now you are pushing it inside the abdomen. Already patient is having obstruction, right? So in that patient, there may be increased abdominal pressure, giving rise to increased intra-abdominal pressure more than 20. So those patients may require ventilation. So patient may require ventilatory support. So it should be measured regularly, that if immediately after the operation patient is not maintaining oxygen saturation, patient may require ventilatory support for 2-3 days. Okay, continue.
Ma'am, this is the last slide.
Okay. So planned ventilatory support is required in all the patients of diaphragmatic hernia.
Ma'am, we have kept an ICU cot ready in case.
Yeah, so the idea is to differentiate between eventration, herniation, and traumatic herniation. Right, eventration may not require any surgical intervention. Herniation would require some kind of intervention, but traumatic herniation may require an immediate intervention in the form of surgery, because the lung will be, there will be decompensation because of acute reduction in the lung volume, correct?
So if such
Yes.
hello, audible?
Yes.
Yes, ma'am.
Yes, ma'am. Yeah.
See, if you are planning for the surgery in Morgagni hernia, so which are the indications for operating from above, from the thoracic route? Specific indication for operating from the thoracic route.
One of the indications is if it is suggestive of herniation of liver, then we can go for a thoracic route. That is in congenital presentation of hernia.
See, I have not operated any patient from the thoracic route because we are comfortable by operating from the below only. So, but a book says that any patient who is very fatty and in a pediatric patient, when there is a hypoplastic lung is there, they say as per the theory that you can go from the thoracic route, and normally thoracotomy is done by the 5th intercostal space, but whenever you are operating for the diaphragmatic hernia, it is from the 7th intercostal space, right? So thoracotomy is done from the 7th intercostal space. And in a very fatty patient, it is difficult to bring all the bowel loops below, and assessing the diaphragm from the below is sometimes difficult. So in that case, you can go from the thoracic route. Right? These two are the main indication. But one thing again, if you are operating in a congenital patient, two things are that. One is a Lard's band, and second is this malrotation. If these two anomalies are simultaneously detected, then you should not go through the thoracic route. Then you should go through the abdominal route. Right?
Yes.
Okay.
Okay, fine. Anything else, ma'am, to discuss?
No, I think few of the things we have already
Enough.
discussed in
Yeah.
last
Okay.
class. Okay.
Yes. Last lecture. Yes, yes, ma'am. Okay, then we'll leave then. Thank you, ma'am.
Okay.
Kashvi, well done, beta. Thank you.
Thank
Okay.
you, ma'am.